The field has changed quite a bit in the last 5 to 7 years as we've identified EGFR mutations and now routinely test for those, as well as ALK in patients with especially adenocarcinomas, but certainly others who have light or never smoking histories. This has led to using EGFR TKIs in the frontline setting, replacing chemotherapy in these patients, which has been a really remarkable turnaround in lung cancer, and especially for patients being able to take a pill for several years sometimes before even looking at chemotherapy. Obviously, to try and build on these strategies in the frontline setting, can we even do better than we already have? EGFR mutation containing tumors, those patients benefit tremendously from drugs such as erlotinib or afatinib now. Even other drugs out there like gefitinib, which may be making a return to the US, but certainly used worldwide. These are very easy to take. They have manageable toxicities. But how can we build on those? Well, one of the strategies has been to utilize bevacizumab. We've tested bevacizumab or Avastin in other settings. There was the beta study, which was in second-line therapy, and we showed some very promising data in the phase 2, and it led to a large phase 3 study, which did show some benefit, but didn't cross that barrier of overall survival that was needed. And this was a combination of, as we called, Avastin and Tarceva. So that was the beta study. And so that was a drug combination that I thought was very promising. However, it was not in a selected cohort of patients with EGFR mutations. The Japanese now have published data in the frontline setting in a phase 2 manner that has shown benefit, increased response rates, increased PFS, and potentially increased overall survival. Again, this needs to be tested in a larger randomized form, but there is promise now that perhaps you can add another biologic to an existing platform and see if there is benefit. So we're hopeful that this and other combinations could increase the overall effectiveness of drugs in the frontline setting. We would still call this a biologic approach to these patients and a non-cytotoxic approach.